want to welcome everyone to an annual symposium that is hosted and sponsored by the Center for Research on Aging in the School of Medicine. Today we have a symposium and poster day. It's a little unusual today is that we're back on, or we continue to be on Zoom. We had hoped to have this session actually been waiting a couple of years with Dr. Freed being our guest a couple of years ago. And then that was right when the pandemic, it became evident that nobody was going anywhere, and we canceled. And then again, last year, we were planning to have this event, and then things picked up again, and it just seemed that it wasn't prudent to continue with an in-person event. So this year we're trying something different. We're having our symposium on Zoom, which will be followed by an interactive poster session, in which those that have posters, and you all should have the abstract book with your Zoom invitation. Those that have posters will be displaying them in private rooms for you to go in and out of to talk with them and anyone else who's there at the time you go in to the room. So this is an experiment and we'll see how it plays. But in the meantime, let me just say that this event is co-sponsored by the Claude D. Pepperold American Independence Center, the Geriatric Research, Education, and Clinical Center in the Baltimore VA, the Peter Lammy Center on Drug Therapy and Aging, the Geriatrics and Gerontology Education and Research Program at the Graduate School, the University of Maryland School of Nursing's Biology and Behavior Across the Lifespan Program, the UMBC Doctoral Program in Gerontology, the Center for Aging Studies at University of Maryland, Baltimore County, and the Erickson School of Aging Studies. And very briefly, Anne, can you put my first slide up? Go to the next. Just want to give you very quickly an overview of the center. Our center, which is based in the School of Medicine, operates on the principle that aging research and training are inherently interdisciplinary and that care requires interprofessional cooperation and collaboration. It's a center without walls, but it does have a home. It has more than 150 faculty from the School of Medicine, where about 80% of the faculty reside, and the remainder come from elsewhere on the UMB campus and outside. The faculty received $99 million in new funding in 2021, and the mission is the facilitation of research and research training in aging. Go to the next slide. I don't know if you can see this, but basically this is a diagram which emphasizes that the center incorporates all of the aging research and training programs that are on our campus here, as well as elsewhere in the University of Maryland, mostly in Baltimore County. We also include programs at the National Institute on Aging in our collaborative efforts. And this is just a way of depicting that, and I will not try to review it with you. Okay. So I guess I've told you a bit about, let me just acknowledge a couple of people. The planning committee for this event, Alice Ryan, who is in the School of Medicine's Department of Medicine and Associate Director of the Center for Research on Aging. Mary Rogers, who is in the School of Medicine and is an emeritus professor in the Physical Therapy and Rehabilitation Sciences Department. Amanda Lenning, an associate professor and senior associate dean in the School of Social Work, and Diane Martin, who is an associate professor and director of the Geriatrics and Gerontology Research and Education program in the graduate school. And of course, Ann Sullins, whom most of you have had correspondence with, who organized the program today and is the program manager for the Center for Research on Aging and our Pepper Center. Before turning to the keynote talk, I want to remind you about if you have any questions or comments during the talk, you can put them up in the chat and we'll be monitoring that, and we'll have time for some questions and answers afterwards. The other thing I would like to say is I'd like to thank Dr. Freed for joining us. It's been a long wait, and we're fortunate that she was able to join us. It's been a long time. Linda and I go back probably to the early 80s when she was here at Hopkins, and we actually did some early work on comorbidity together. I remember sitting in your living room, Linda, and watching I think it was your son riding up and down the block with his helmet on, and you were trying to work on a presentation with me on multiple morbidities. Who would have thought all these years later, it's finally come to the fore as a critical issue in aging, but that goes back a way. So I guess without any further introduction on my part, I'd like to now turn to Dr. Reese, who's the Dean of the School of Medicine, who will introduce Dr. Freed. Dean Reese is also the Vice President for Medical Affairs for the University of Maryland, and he's Dean of the School of Medicine. He's also the John Z. and Akiko K. Bowers Distinguished Professor. Dr. Reese.
Thank you, Dr. Magaziner. Can you hear me okay?
Yes.
Wonderful. Well, I too want to welcome Dr. Freed, but let me say I want to welcome everyone for coming together for this third annual Aging Research Symposium. The University of Maryland School of Medicine Center for Research on Aging, as Dr. Magaziner has pointed out momentarily, has been around for a while, since 1997. And the center, as you know, is led by Dr. Jay Magaziner as the director and Dr. Alice Ryan as the newly appointed Associate Director for Translational Sciences. I have, in preparing my comments, I've been on a fast track learning curve in aging research, which, as you know, my research is at the other end of the spectrum, and that is in developmental biology. But I've learned that between 2015 and 2050, the proportion of the world's population over 60 will have nearly doubled from 12% to 22%. Today, persons age 60 and older outnumber children under 5 years of age. The current pace of the population aging is much faster than it had been in the past. And this is a field of research that is critical to both the human lifespan as well as the human quality of life. As the English writer and philosopher and art critic John Ruskin once said, and I quote, "Quality is never an accident. It is always the result of intelligent effort," unquote. The aging epidemic is a real concern, and it takes real work to address its health consequences and challenges. This is why we're here today. So I thank you for your dedication and your commitment to the field of study. This is something that the School of Medicine applauds, supports, and encourages. I'm delighted that our keynote speaker is Dr. Linda Freed, a friend and a colleague, an internationally acclaimed scientist and thought leader in aging research. Dr. Freed and I have had the good pleasure of working together as members of the National Academy of Medicine's Governing Council. One may say we were seatmates. We would sit together often and have her sidebars, which were always very interesting. But in all seriousness, Dr. Fried is indeed, as Dr. Magaziner points out, the Dean of the Mailman School of Public Health and the Delamar Professor of Public Health Practice. She's also Professor of Epidemiology and Medicine. By the way, can you hear me? My computer said you're about to be signed out.
We hear you.
Okay, well, I'll keep going until that, unfortunately, maybe doesn't happen. Dr. Fried is trained in cardiovascular and chronic disease epidemiology and geriatrics, and she has dedicated her career to the science of healthy aging and creating a health lifespan that matches or increased life expectancy. Her work focuses on the prevention of frailty, disability, cardiovascular disease, and defining how to transition to a world where greater longevity benefits people of all ages. Dr. Fried has also led seminal work in defining frailty as a new clinical syndrome and illuminating its causes. She has led major population-based studies to determine the causes and the consequences of chronic diseases. She has co-designed and co-founded Experience Corps, a community-based senior volunteer program. This evidence-based public health program places older volunteers in public elementary schools to support both the academic success of children and the health of the volunteers. Dr. Fried has authored over 500 peer-reviewed publications and has served as principal investigator for several major longitudinal cohort studies. At Hopkins, she served as the founding director of the Center on Aging and Health. She also served as the director of the Division of Geriatric Medicine and Gerontology and director of the training program in epidemiology and biostatistics of aging. As I mentioned earlier, she is a member of the National Academy of Medicine. She's now a re-elected member of the Executive Governing Council and serves also as co-chair of the National Academy of Medicine Global Commission to create a global roadmap for healthy longevity. In 2014, Dr. Fried was named among the top 1% of most influential scientific minds of the past decade by Thomson Reuters. And in 2012, by the New York Times, as one of the 15 world leaders in science. She's recipient of numerous other honors and awards. Dr. Fried, we're extraordinarily pleased, honored, and delighted that you're here to be our keynote speaker. And at this time, I'll turn the podium over to you. Thank you and welcome.
Thank you so much. It's my honor to be here, and I've really been looking forward to this. And now I'll see if I can build on your introductory comments, not the introduction, but what went before that. So Dr. Magaziner asked me to talk about the implications of longevity for public health and epidemiology. And I would like to say, to start with, that when I'm saying public health and epidemiology, I'm talking about how fields need to transform in the face of longevity. I would also say that that's equally true for medicine. But this is all about the public's health and how we accomplish that in the context of longer lives. So may I have the next slide, please? Let me start from the point of view of your developmental biology background, Al. We have created the most astounding thing in human history, practically, as a product of 100 and more years of societal investment in health and education. We have created longevity. That means that the children we wanted to save from dying in childbirth are, in many countries, less likely to die, that women are less likely to die from in childbirth. People are less likely, except in this pandemic, to die, but even now in this pandemic, from infectious diseases, et cetera. And what has this wrought? Next slide, please. Well, I would say that it has wrought a real transformation. Here you see a schematic of human life expectancy at birth since the beginning of human time. And you can see that up until about the mid 1800s globally, human life expectancy at birth was 24 years. Since that time, it has risen steadily and continues to rise. And I would say the critical thing to understand is that we have wrought this by intentional investment, and it is essentially amounting to a revolution, a demographic revolution that is transforming all of our futures. Now, next slide. Now, how did we get there? Well, as I said, one way we got there is by saving children's lives so that children are not dying in childhood. And here you see the dramatic declines in childhood mortality globally from 1950 to the present and projected to continue for the world in the solid line and for sub-Saharan Africa and South Central Asia in the two other lines. Next slide. The world has gone through predictable transitions. We've gone through what we call a first demographic dividend, where this decline in infant and child mortality leads to a decrease in fertility so that women start having fewer children. And as children actually, that persists as children survive to adulthood. Then, as children survive to adulthood and they start assuming investments in education as well as health, the labor supply becomes greater than the number of dependent children, potentially fueling economic growth and giving countries the resources to further invest in their human capital. And then we see a predictable second demographic dividend, which almost all the countries of the world are now in, with persisting declines in mortality and fertility, continued improved survival so that the population's really living longer and longer. And then, as Dr. Rees said, the age structure changes and you start seeing an increased proportion of the population, which is older. Thus far, demographers and economists who describe these demographic transitions and dividends have basically said that what we get out of all of these longer lives is more lifetime savings. I would like to argue to you that we get a lot more than that, but we have to build it. Next slide. First, what we've gotten is also astounding, a product of societal investments for over 100 years. We have added 30 years of life expectancy to our lives. Life expectancy at birth, with life expectancy in the US in 1900 being 47 years on average, 39 years if you were African American. In 2010, life expectancy has risen almost 30 years for everyone and is now close to 80 years. This 30 years of increased life expectancy is an astounding feat, unprecedented in history. I would like to recognize that 25 of those 30 increased years are attributed to prevention, largely through population-based public health interventions, policy and regulatory measures, as well as more recently based on improved medical care. Next slide. So as Dean Rees said, a product of all this is that we are becoming an aging society. This year is a landmark year on two counts. One is that this year, in the US, there is as high a proportion of older adults in the population, 15%, as there are children under 15. That's the formal definition of an aging society. And from here, the expectation is that happily, assuming our recovery from this pandemic, we will start to see a continuing increase in life expectancy and an increase in the proportion of the population that's older. Next slide. Now, the journey to global longevity in aging societies has been a long one, we think. Can I have the next slide? It's been a long one. Here you can see the length of time for countries to go from, on the bottom line, 7% of the population being 65 and older to 14%, so doubling the proportion. Now, what you see is that it took France 120 years to get there, Sweden about 100, the US, it's taken about 50. And you can see that in low and middle income countries, they are accomplishing this in 20 to 40 years, an astounding rate, again, for all the same reasons. So every country of the world now has longer life expectancy as a product of societal investment. Next slide. And globally, this year is a landmark year because it is the year of a crossover with equal numbers of people 65 and older in the world compared to children under 5, excuse me. Next slide. So we've essentially created a new stage of life. Again, an astounding feat, adding 30 years. I would like to talk with you about where the opportunity lies so that we don't think of this, as Dr. Dean Rees said, as an epidemic or a pandemic or a tsunami or a silver catastrophe, but we in fact make the next round of investments so that we see this new stage of life as an opportunity of grand proportions, unprecedented proportions for all ages. And I believe the evidence suggests this is possible. But what will be key is the health status of people who are living longer lives. Will people be living these long lives with health or in illness? Next slide. So let's look at a few scenarios. And this is a wonderful slide, which is probably familiar to Dr. Magaziner because it was created by Dr. Jack Gorelnik, and he graciously lent it to me. Let's think about, say, life expectancy in 1990, 79 years. And some proportion of that is spent in years disabled in the red, and a much larger proportion, most of one's life, hopefully, in green, disability free. Next slide. Now, what happens if we continue to extend life expectancy, which we expect to be able to do? Let's say to 83 years, 82.8 years. One possible scenario could be that we extend the number of years in healthy life, but don't change the number of years living with ill health and disability. Next slide. Another scenario could be what we call the compression of morbidity scenario, where we similarly extend the length of life, but compress the number of years spent disabled as well, so that we see a decline in both the proportion of years spent disabled and the actual number. Next slide. And the other scenario we seem to be confronted with is a continued extension of life expectancy, but an extension and expansion of years spent ill and disabled. Which scenario would you vote for? Well, my guess is that this is a no-brainer, and it's not scenario 3, and it is scenario 2. I'd like to, however, we are increasingly confronted with evidence that we are living scenario 3, and I'd like to present to you some of the evidence that we could shift to a scenario 2, and that would make all the difference in the world. So if I ask my undergraduates and graduate students, do they want these longer lives? 97% always say yes. And then there's this very sharp 3% who always say maybe. And the maybe, and if I ask them why they're saying maybe, they always say, depends whether I'm sick, excuse me, or healthy. So our students get it. And the big question for us as health professionals and leaders is, will we be able to make our health span equal to our longer life expectancy? Excuse me, will we be able to make our long lives be healthy? Next slide. Now, why do we want this? Well, to say some of the obvious, of course, health is essential to well-being. Health is a good in itself. Healthy aging would diminish healthcare needs and costs. But there are other reasons as well, because older adults turn out to be the world's only increasing natural resource, with a huge amount of unrealized social capital, with pro-social needs to give back to society and to those who follow them. These are unprecedented assets that we have not yet designed a society to realize. And if we could confer health across longer lives for everybody using the science we now have, as well as the science we'll create, then we would create the conditions in which individuals and society could realize the social capital. Next slide. I'll show you what some of those assets are. The science now is immensely exciting to show that not only do people actually accrue knowledge and expertise over their lifetime and not lose it as they get older, but in fact, they build on a lifetime of experience and expertise to develop new assets of the ability to recognize and solve highly wicked and complex problems that they didn't have the skills to tackle earlier in their lives. The ability to unify their learnings from their personal life experience with their learnings from their expertise and objective experience, and arrive at what some scientists would call wisdom, the unification of those two based on values and judgments about what matters, and acted upon to secure betterment for individuals and for those around them. And finally, novel kinds of creativity, which are aligned with these unprecedented kinds of abilities. Older adults bring some increased time to devote to their generative goals, which is the desire to leave the world better than they found it, and pro-social motivations that escalate with age to improve the well-being of those around them. Good health and function would confer the ability to utilize these assets and could offer the potential for unprecedented social capital at scale across longer lives, which could benefit all ages. Next slide. So the key in the lock is whether people will be living longer years, healthy or ill. Next slide. So let's think about how we got here and what that means about where we need to go. The public health people here will understand very well that we have gone through, in the last 70 years, a dramatic epidemiologic transition on top of the demographic transition I just described. Next slide. This epidemiologic transition looks a lot like this. Here are the leading causes of death for the US in the left-hand two columns, and now globally from 1900 to 2005 or 2002. And what you see, of course, is that in the US in 1900, the top three causes of death and most of the others were infectious, whereas in 100 years later, the top seven causes of death, aside from accidents, are all chronic diseases. The same patterns have happened globally in this epidemiologic transition, absent, of course, a pandemic or increasing pandemics. And what we see, next slide, please, what we see now globally, what we see in the US is that 80% of deaths are now due to chronic diseases. Next slide. And globally, what we see is whether you're talking about low-income countries, lower middle-income countries, upper middle-income countries, or high-income countries, chronic diseases as causes of death in the orange bars are either equal or dominant causes of death, as well as of morbidity globally. This epidemiologic transition has huge implications, but also huge opportunities for us. Next slide. Excuse me for coughing. I'm just getting over a cold, and this doesn't seem to be much I can do about it. So I'd like to talk about how this epidemiology of chronic disease informs and is changed by thinking about our now longer lives and the health outcomes and how health outcomes expand with aging. Next slide. So I'd like to summarize, perhaps a little too glibly in this figure, what we've learned over the last 40 years in terms of causes of an array of chronic diseases in the right-hand column. What we have learned is, first of all, important to point out that there are a number of risk factors: smoking, obesity, physical inactivity, as well as a whole range of environmental and social determinants of health that contribute causes to each of these diseases. But notably, we've learned that many of these factors cause multiple of these diseases, and that in fact, any one of these you can calculate. So smoking itself causes 14 different chronic disease outcomes. We also have learned that there are shared biological pathways like inflammation, which contribute to these diseases. So 40 years ago, we were talking about the mechanisms of single diseases. Now we're confronted with the fact that many diseases result from shared causes, and that changes how we think about prevention. Sorry, next slide. Now, so we've learned that not only do these risk factors trigger, going back to Jay's comment, multimorbidity, sorry, but they actually can be risk factors for each other. And that if all we do is look at a single risk factor or multiple risk factors in a single end-organ disease outcome, we may miss the full import of what's going on, or where the opportunities for prevention or treatment lie. Next slide. We know, for example, that end-organ disease outcomes are not independent. I'll give you, next slide, I'll give you an example. So certainly cardiovascular diseases co-occur. We know that vascular disease prevalence increases with age in all vascular territories, and that about a third of octogenarians have vascular disease in at least one arterial territory. And the odds increase in each arterial territory for every 10 years of age. Next slide. We also know that there's another profound change that happens in terms of expanding health outcomes, so that a single disease is no longer the sole outcome that we have to think about with aging. With aging, diseases themselves become risk factors. They become risk factors for other diseases. They become risk factors for becoming disabled. They become risk factors for frailty and for falling, as well as for mortality. Next slide. Here's an example from the cardiovascular health study. These are unpublished data, which we analyzed, looking at coronary heart disease in this cohort of 6,000 men and women 65 and older in 4 US communities. And what you're looking at is the months before or after an incident coronary heart disease event, which is in the middle between the two dotted lines for this cohort. And you're looking at self-report of no difficulty in an array of tests before the event, with the array of tests being organized by the energy level of the test. So the high energy tests in the dark blue, you can see that at baseline, 36 months before the incident event, a little less than 60% of the cohort reported no difficulty in high energy demanding tasks of climbing a flight of stairs or walking a quarter of a mile. About 82% or 84% reported no difficulty in medium energy demanding tasks of doing heavy housework. And about 90% reported no difficulty in low energy demanding tasks like walking across a small room or one block. What you see, though, is that after the coronary heart disease event, myocardial infarction, there is a decline in the proportion without difficulty for all of these tasks. Essentially, evidence of the impact of coronary heart disease event on function and its persistent decline over time, persistence and decline, and perhaps offering a fingerprint of the effects of this disease on function. Next slide, please. So we have a situation in which the conditions for multimorbidity are set and likely to emerge as people get older. Next slide. And in fact, multimorbidity becomes the norm with aging. Next slide, please. If you look at Medicare beneficiaries, 2/3 of Medicare beneficiaries 65 and older report 2 or more chronic diseases, and 1/3 report 4 or more. Next slide. Now, with this background, I think the very important news, which we've also learned in the last 40 plus years, is that health is actually malleable into the oldest stages. This is where our opportunity lies. Next slide. And I have to honor Leon Gordis in this, since much of what I'm going to rely on here is epidemiology as the basic science of disease prevention in my comments that follow. Next slide. So summing over 40, 50 years of science, what the CDC and the WHO now say is that if you look in the bottom right, that a high percent of what we call non-communicable diseases are preventable. 80% of stroke, heart disease, type 2 diabetes, and 40% of cancers. Those are stunning numbers. That we have learned that this prevention works and matters at all ages. And we have learned that the societal return on investment for effective investments in prevention is very high, conservatively fourfold, but likely that is very conservative. We've also learned that if we invest effectively in prevention and people arrive at age 70 healthy, they're tracked to stay healthy well into their older ages. Next slide. Now, we do also know that if we delay the onset of one disease by 10 years, it leaves room for others to emerge. Suggesting that as we think about prevention, we're going to need to develop new windows through which to think about preventing disease, both conditioned on whether another disease is present that may create risks for a disease or disability, or conditioned on the fact that the person has risk factors but hasn't even yet gotten the disease. Next slide. Now, the very exciting evidence, on top of the evidence we now have about the preventability of non-communicable diseases, is that the US has been conducting what I would, I guess, cynically call natural experiments, which have been demonstrating that there is potential, that it is possible for human beings to live this long life expectancy with long health or health span. One example comes from a report from Ken Langa and colleagues in 2013, in which, from the US Health and Retirement Study, they reported that from the year 2000 to 2012 in the US, in people 54 and older, there was a 25% decline in dementia incidence. That's a stunning decline over 12 years, stunning. If you look carefully at that report, what becomes clear is that this is an issue of a subset, that this decline, which was so dramatic, occurred in the subset of the US population who have been the beneficiaries of a lifetime of more education and of health promoting conditions, living in healthier and nurturing environments, served by stronger public health, and with better access to the right medical care. That this is occurring just in a subset of course, demands that we figure out what's going on here so we can generalize it to everyone. But that it is occurring gives us a model of what is possible that we could generalize. Thank you. Next slide. So there have been a number of other US natural experiments on health which come to offer the same conclusions, that it is possible to live long with health or with illness, but that it is possible to live long with health, and that we know that prevention works well into the oldest stages tells us that health is modifiable in very big ways. And that effective investments in healthy environments, in human capital, in health behaviors across the whole life course, which are causing the better resource segments of society to arrive at old age healthy and stay relatively healthy, now need to be expanded to everyone. Because those without these cumulative advantages accumulate ill health, and we're seeing that big time, and it was certainly exposed in the pandemic, accumulate ill health by middle age, and are at much greater risk of serious illness, morbidity, and disability in older age. Next slide. Now we're seeing this globally as well. Here's one example. Here's a report in PNAS by Skirbeck in 2012, in which he looked at compared nations in different regions of the world in terms of cognitive performance at different ages. And what you can see here, comparing, for example, in the orange, the US in the top line and Northern Europe in the black that's overlaying it, you can see cognition at different ages compared to in the bottom lines, China in the purple, Mexico in the brown, the dark blue is actually Southern Europe, and India is green. If you compare those, what you see is that at basically any older age, people in Northern Europe and the US have higher cognitive function than people 30 years they're younger, 30 years younger than them in the other countries. So the conditions of a society appears to be directly related to the cognitive performance of the people in that society. And key to the kinds of investments that different countries are able to make in the cumulative opportunity for health and improved cognition, including education, of course. Next slide. So if we could actually create healthy life expectancy, long life expectancy with health into the oldest stages, what would the potential be? Next slide. So let's think about healthy life expectancy for a moment. That's defined as the expected number of remaining years of life spent in good health for a particular age, typically birth or age 65. Next slide. And what you see here for the world is that the proportion of years and the number of years with healthy life expectancy, the number of years has been increasing globally, while the proportion of years is, or the number of years lived with disability appears to have expanded slightly as well. Next slide. Here you see healthy life expectancy in the light blue of each bar, and total life expectancy in the whole length of the bar for regions across the world. And you see huge variation in both measures, in total life expectancy and in healthy life expectancy, going from high income Asia Pacific at the top to Central Sub-Saharan Africa at the bottom. Next slide. If you sum over all of these, what we see is that between countries, there's a range of 38 years for life expectancy at birth right now, 37 years for healthy life expectancy at birth, and a range for those who reach age 60 of 13 years in terms of their future life expectancy. We also are seeing that the gap in life expectancy at 60 years is growing between high and low and middle income countries. Next slide. So actually the disparities in the opportunity for healthy longevity are increasing. Next slide. You can see that here for globally, for global data, that in 2000, the gap between life expectancy and healthy life expectancy at birth for men was 7.3 years, and for women was 9.7. And by 2019, the gaps had increased for both men and for women. Next slide. Now, Eileen Crimmins has said quite cogently that for the US, but also we should think about for the world, we need a focused effort to improve health, increase life expectancy, and remove social differentials across the life course through improved health behaviors, absolutely, and social policy that enables that, to see both increased life expectancy and health expectancy reaching, so the populations can reach the potential for health that the science indicates is possible. Next slide. So I'd like to offer some final thoughts. First, that as Mary Tinetti and Terry Fried said a number of years ago, it's time to go beyond the disease era in thinking about how to get to goal here. Next slide. The history of medicine and the history of public health science both originate in the study of disease since the 1880s in the US. But in fact, we know that disease matters, but that much more than disease affects health and affects disease. Next slide. You can even see that in these data from the Nurses' Health and Health Professionals follow-up study, showing that if we looked at people age 50 who had none of the low, let me say this differently, who had 4 to 5 positive or low risk factors for chronic diseases, compared to those with no low risk lifestyle risk factors, that turned into a difference of 9 or 11 years of healthy life expectancy for women and men. And not following a low risk lifestyle predicts 90% of diabetes, 80% of coronary heart disease, 70% of cardiovascular mortality, 50% of cancer mortality, and much more in terms of other health outcomes. Next slide. And the much more is also in terms of thinking about how these factors and much more affect aging itself and health as opposed to disease in aging, and how societal and environmental factors affect all of this. If our goals are to extend health span so that it's equal to the extended length of our lives, we're going to have to expand our inquiry and our actions to incorporate the science across all of these dimensions. Next slide, please. So I'd like to touch on some points for consideration. One, of course, is that we know, next slide, please. We know that health is a product of multiple determinants, societally, and the social determinants of health, which require every sector of society to be a player in the creation of health span, increased health span. Next slide. We also know that public health and medicine have unified responsibilities in terms of delivering the science through clinical care at the top of Tom Frieden's pyramid here, sharing in the delivery of long-lasting protective interventions like vaccinations in the middle horizontal, and at the bottom two, public health-led responsibilities for changing the context so that individuals' default decisions can be healthy, and so that socioeconomic factors that contribute to ill health are solved. Next slide, please. I'll end with comments about aging itself, which of course we now are learning is a causal factor in disease. And aging begins developmentally, Dean Reese, as you know, at conception. Aging turns out in the face of inquiries about specific diseases to offer stronger risk factors, for example, for dementia than carrying an ApoE4 allele. Quite remarkable. Next slide. So studying the underlying aging processes may start to offer a whole new layer of public health and medical insights and solutions. Next slide. There's the new geroscience, which I don't have time to go into today, but the hallmarks of aging, the biological, the cellular and molecular processes that contribute to the processes of aging appear, many of them now, to be malleable as well. And with immense amount of science going on to learn where there are opportunities for intervention, whether behaviorally or therapeutically. And there's exciting evidence that slowing biological aging might well have huge potential to prevent diseases, multimorbidity, as well as declines in function while improving health span. So very exciting potential. Next slide. We're also learning that aging is a life course process. For example, dysregulation of not just any system, but a threshold number of systems can incrementally occur across the life course and can culminate in threatening the ability of the human organism to maintain homeostasis and adaptive capacity. This culminates with aging in the presentation of a clinical syndrome and phenotype of frailty when this threshold dysregulation gets particularly severe. Next slide. But what we've learned through work by Dan Belsky and others is that we see in young adults physiological dysregulation offering a marker of premature aging in a subset of young people. And in fact, this is in the absence of disease, but accelerated by history for these young people of adverse childhood exposures. Next slide. I'll show you a little bit of these data. This is from the Dunedin study looking at 26 to 38-year-olds and following them from 26 to 38 years, so over 12 years. And what you see is the aggregate shifts in different organ biomarkers over time. Next slide. But I want to particularly point out that the longitudinal change showed that actually the pace of change varied very much from person to person, from zero change over the period of 12-year follow-up to 3 years of accelerated physiologic change per chronological year for some people. And what we saw is that those with accelerated biomarker dysfunction showed a range of outcomes, or even at age 38, that we associate with aging, from declines in cognition and physical function and more self-reported difficulty to older retinal vessels and greater apparent age. Next slide. And you can see some of that here in terms of the declines in grip strength. Next slide. What you see in frailty is that the same kind trajectory of dysregulation emerges at a threshold level to be associated with the emergence of a phenotype of frailty in a clinical syndrome. Next slide. And next slide, please. And so that when this dysregulation of many physiologic systems goes past a threshold point, people present as frail, generally in older age, sometimes in association with highly catabolic diseases. Next slide. As I said, frailty is a clinical syndrome, or the evidence certainly indicates that, a syndrome of shrinking and slowing and weakness with low activity and low energy, which predicts poor outcomes and appears to be a consequence of a vicious cycle of energy dysregulation. Next slide. These are the components of the frailty phenotype, with 3 or more of them consistent with evidence of being frail. Next slide, as is consistent with the definition of syndrome. Being frail is highly predictive of mortality. Here you see Kaplan-Meier curves indicating that over 3 years, follow-up in the cardiovascular health study, those who were frail at baseline, only 81% were still alive at 3 years compared to 97% of those who were not frail. Next slide. And risks of other outcomes are high as well: incident falls, worsening mobility and disability, and risk for first hospitalizations. Next slide. And what's going on physiologically shows that the people who are frail in the purple are highly dysregulated in their ability to handle stressors. Here you see the response to a standard clinical glucose tolerance test in women who were 85 to 94 years in the Women's Health and Aging study. And you see highly dysregulated response to oral glucose load compared to those who were pre-frail or non-frail. This is both the glucose response and the insulin response. Next slide. So frailty is a multi-system disorder, if you will, of the core regulatory systems that maintain our adaptive resilience, the metabolic system, stress response system, and musculoskeletal system. And when those are in combination significantly dysregulated, then the vulnerability of physical frailty is physiotype and the phenotype emerge. Next slide. So people who are frail demonstrate diminished ability to tolerate stressors, and when it becomes severe enough, diminished ability for survival. Next slide. So I'll end by saying that all of these perspectives add up to longevity in the continuum of aging, I think, opening up new views for public health, for medicine, and for the science of epidemiology. Next slide. Epidemiology itself offers a new basic science that I just gave you a little window into on the biology of dynamical systems of aging that culminate when dysregulated in frailty. Next slide. But healthy longevity necessitates a whole new lens, the need to create healthy longevity for everyone and the opportunities. There's a necessity for us to reshape our public health lens or medical lens, and both focused on how we promote health and prevent disease, disability, and injury in order to have a 100-year life where people will be living these longer years with maximal health. Next slide. How do we accomplish a compression of morbidity? Well, I hope that I've given you some summary of perspectives about what we need to be focusing on here as the major global and national goal for improving the health of our aging society. Next slide. And the truth is that we're not seeing a compression of morbidity. We're seeing, in fact, a decompression of morbidity, as recent editorials have opined. And so how we turn that around is a critical issue for our collective future, whether we're investing in young people or old people to compress morbidity. Next slide. We have to turn towards extending health span as the population health goal for the 21st century, defined as a long life free from chronic disease or disabilities of aging, and with a lengthened healthy life expectancy, significantly lengthened. Next slide. That will require, I think, medicine and public health turning to not just improving health or treating disease right now, but at every age and stage of life, investing in that person's health futures so that they can arrive at old age healthy, so that they are tracked to stay healthy. It will require rebalancing the investments between public health and medicine so that we are investing with the highest return on investment in prevention and assuring that public health and medical care are going in the same direction. Next slide. And resolving health disparities across the life course is going to be the essential element to compressing morbidity. As I said, those who are not the people who manifest health disparities are showing this as possible. And now the key is to generalize that, to raise the floor and the ceiling of health for everyone. Next slide. Health and health span are essential, the essential key in the lock to experiencing the benefits of an aging society. Those potential benefits and opportunities are huge, but only if we extend health span. Next slide. They look transformative for all ages. What older adults want to contribute to those around them, to the generations that follow, are tremendous. We could build a society for longer lives in which we experience that coming to fruition, but it needs to involve an increased health span. And it could, next slide, it could look like this amazing volunteer in Experience Corps, like thousands and millions of others, with a desire to give back and the ability to create positive futures for everyone. Thank you.
Thank you, Linda. Thank you very much for that. You covered so many parts of the landscape of what could be done. I was going to ask you about some of the biological factors that covered that, the social and economic and political factors. Those have been known for quite a while, but I think the biology, the action in biology and the involvement of biology in some of the epidemiologic work has a lot of potential. And do you think that we're going to be seeing sort of biological interrupters in this process? If you go back to, you've got the social and political and economic factors, which are going to change, unfortunately, ever too slowly. Yet we have to be working toward making those changes and helping those changes to take place. Behavioral changes might happen a little faster. Biological discovery is in full force, but will we see a time in where we can actually interrupt some of the biological processes in order to improve the lifespan? And how do you think that's going to come about?
So I'm going to respond from my own point of view, but I also recommend, as Dean Reese mentioned, in a week, the National Academy of Medicine will be releasing its newest report, the Global Roadmap for Healthy Longevity, in which much of what I'm going to say right now is, and much more than that, is covered. I think we have tremendous opportunity to transform health futures starting today, even while we're awaiting the results of some of the biological discoveries that I am optimistic about. I'll give you a couple of examples. I believe that there is a moment in time right now coming out of a pandemic when to say that public health was not able to deliver its full significance in this pandemic is the world's understatement. But that's a consequence of US disinvestment in public health since 1960. The US public health system now gets no more dollars than it did in 1960, not even inflation adjusted. And in this pandemic, we have seen the consequences of that. The public health system's responsibility is to deliver health in every community in the US. But it has not had a trained workforce, and it hasn't had an effective infrastructure. It doesn't even have data comparability or transmissibility or collection capabilities nationally. And it has not had the boots on the ground to conduct what the science says is possible. And its job is to enact on the ground in every community, as well as through policy, the conditions to make health possible and available for everyone. So I would say if there was one thing we should be doing right now as a health community, we should be advocating for reinvesting in a public health system that delivers at least 70% of a population's health, along with those social determinants of health. And there are interactions between what we need for public health, like lowering air pollution, and what we need for controlling climate change. So the return on investment, the New York twofer, if you will, is very high. I would also focus, of course, on how so think about the biology and how that amplifies our understanding of the value of health behaviors. So I'll give you an example. We know, for example, that if I said smoking causes 14 diseases, I can tell you that physical activity prevents at least 14. And what physical activity does as well is essentially tune up the entire organism, like taking your car in for a tune-up, so that every single level, molecularly, cellularly, physiologically, interactively, dynamically, every level of the human organism is upregulated and improved in function by physical activity. And in some cases, physical activity is actually even more effective than medical therapies. If you look at the diabetes prevention trial, what you saw is in older people is that the physical activity arm got even more benefits in diabetes prevention than the metformin arm. So I think we need to recognize that we are going to need a mixed menu of approaches, but we need an aligned call for investments in prevention at every age and stage of the life course, starting now. We need a strengthened public health system, and we need a medical care system that is really invested in prevention and aligned with these goals of health futures as well as health presence. That's starting there, and doing that actually would do a lot to prevent not just chronic diseases, but also to prevent multimorbidity.
Thank you. We have time for maybe 5 minutes of questions. Let's see what we've got. If anyone has a question, let's see. Do we have any questions in the chat right now? There's a lot of appreciation. Of course.
So I'll respond to Dean Reese's comment, which of course is very exciting. My guess, Al, is that there's a lot to learn here. I just read your comment, and I'm sure I don't understand all the dimensions of this very sophisticated science. But I think that there are probably some key lessons to learn there, particularly worrying about chemical or biological disruptors. Aging itself looks to be pretty complicated. So, and I would imagine what you're looking at is also similarly complex, but it would be exciting to think about the potential. I see a comment from, oh no. Are there any other questions or comments or challenges or arguments? I always like arguments.
Dr. Fried, can I ask a question?
Yeah.
Yeah, I was typing, but I thought it's better to talk. Thank you for the terrific presentation. And I'm a geriatrician and also palliative care physician. And then so I'm originally from Japan. And then when I was in Japan, I was, seeing a lot of old people, very old advanced age people, because it has the longest life expectancy. And I was seeing so many people who's in 90s, and then they said, oh, this is my first time to come and to the hospital, and I've never seen even doctor, and then this is my first time. And then most of them are, working most of it, I was working in countryside, so they're making like vegetables, and then, oh, doctor, I gotta go back and I gotta, take care of my vegetable. These people are very healthy. And then I had an impression that, if they keep working instead of like retired and then just spending vacation, I thought, working people are more healthy. So I have two questions based on your presentation. One is, so because now the definition of geriatric population is 65, but as the healthy lifespan expand, and I know the definition of 65 is actually coming from something like a financial rather than biological reason. So I'm wondering, is it reasonable to start thinking the definition of geriatric population that cut off 65 to change to something like a 70 or even 75? That's my one question. And the second question is and then that means also retirement age may need to be, considered to be changed and actually may promote more healthy aging. So I want to hear your opinion. Thank you.
Questions. Thank you. Well, these are questions on certainly on the minds of people in Japan and Singapore and South Korea, where they're close to having 40% of the population being over 60 already. But your observation, I think, is now borne out by the data. I didn't have time to talk about it, that staying actively socially engaged, staying engaged in volunteering or contributing to others around you, and continue to work if people want to, all contribute to increased health in longer years and improve function and decrease frailty and prevent actually cognitive decline. So the challenge is that we live in societies that were designed, if they were ever designed, for life expectancy of 47, 100 years ago. We have almost doubled our expectancy, and we've never designed a society for the second half of life. That is, and we've never designed health systems for the second half of life, to tell you the truth, with a few minor, small exceptions. So how do we actually now grab this bull by the horn and start designing to actually create roles and meaningful responsibilities for all of us as we get older, ones that are designed to enhance health and well-being, not for indentured servitude, where people who want to work can, where people who want to contribute have roles that use their immense assets rather than putting older people in corners licking stamps. We've shown an experience core, which is a very carefully designed public health program, that in fact, carefully designed roles for older adults that really matter for the academic success of children also confer advantages in terms of improved health and decreased cognitive decline, as well as other benefits. So I think how we design for the future that incorporates the kinds of questions you're asking is very important. Many countries are, and the US has done this, have tackled increasing the retirement age. What we haven't yet tackled is actually creating a workplace and employment that actually keeps people hired and trains people for continued growth rather than relegating them to old jobs without growth. So I see the note that raising the retirement age is tricky, and I totally agree with that. Because many people, particularly those in lower paid jobs, are exhausted and in less good health, and deserve the opportunity to retire. And that was why I was trying to be careful to say, if people want to work longer, they should have the opportunity to do so. Our economies will be the better because we have a shrinking younger population in many countries of the world, as people are living longer and birth rates decrease. And we're going to need to have economically viable societies for people who can continue to work longer. So there's one other thing I would add, and that is the issue of loneliness. Loneliness is a big deal in Japan, but it's actually for older people, but it's actually a big deal globally. and how we design societies for longer lives that enable people of all ages to be significant participants in society, to be significant contributors, to believe that they have a meaningful place and role in the center of that society, and that they benefit from intergenerational exchange and synergy. And that leads to a sense of intergenerational cohesion for a better future. All of that, I think, has to be part of a robust society of longer lives. And I'll just add, I just saw Jack Goralnik here. Jack, I didn't see you before when I said thank you for your slide, but double thank you for everything.
Linda, if I may, I have a comment. And as a follow.
Al, that was Al had his hand up. Yeah, Al, why don't you have the final word? Because we're gonna transition to the posters in a moment.
I was just, my question really is a little spin-off of what I posed earlier. And that is, I realize we focus on the end of, almost the end of life aging. My sense is, this is not my field, that from developmental biology, you can get aging in utero. And is it possible that one should be looking at aging in the young to see whether or not aging in the young portends to much more rapid aging later on, or much more disease later on? So we can intervene at an earlier age, even in the 20s or the 30s, as opposed to intervening in the 70s or 80s. So we're looking at the pace of aging as opposed to just the absolute aging, the way we think of it.
Absolutely. And I think Dan Belsky's really landmark work was I think has transformed our understanding of exactly what you're saying, that we're seeing evidence of aging even in young adults. Now, we haven't gone, the science is only now moving younger than that, but I think the potential is huge. And it may well be that this potential is fundamental. How we address that is fundamental to how we actually solve and end health disparities.
Thank you, Linda. Thank you for that. And thank you, everyone, for joining us today. And I think we definitely got overtime, and doesn't seem to bother anyone. So I guess we're okay. And Linda, thank you so much for your thoughts and insights into many issues. And I think what we'll do is let Anne come on and Sullins and describe how the posters will be operating. Anne?
So we have for 2 poster sessions. So we're going to start the first one, which are the odd numbered poster presenters that were in the booklet and the handout that were provided. So everyone will be able to go freely from one room to the other. The poster presenters will be in each room. They will have their poster displayed. You can ask them questions, they'll present to you, and then you can leave the room when you're done and you can enter another room. We'll end this at 4:15, at which time we'll start session number 2, which will be the even number posters. And we'll do the same thing for 30 minutes. So I will go ahead and open up the rooms.
And thank you all. It's been a pleasure to be with you.
Thank you.
Linda, thank you. Bye-bye.